We also saw that the folks that were coming to quote unquote save us, that their house wasn't in order. Do you know what I mean? We saw that their health systems were overwhelmed. We saw that their communities didn't believe or trust them. We saw that they didn't have experience fighting infectious diseases like we did on our continent. And instead of like the humility to come and ask us, they were kind of just, actually allowing people to die.
Hello, and welcome to the Global Health Unfiltered podcast, a podcast about unspoken realities about global health in Africa and the world. I am Desmond Jumbam, your host for this episode, and I'm being joined by my co-host, Ulrich Sidney. Hi, Ulrich.
Hi, Desmond.
So we'd like to start by thanking each and every one of you who tune in every 2 weeks to listen to our episodes. This show is only possible with your support, and we're truly grateful for that support. So be sure to like and share the show with your friends and colleagues. And also reach out to us if you have any feedback, questions, and suggestions at unfilteredgh@gmail.com. Thank you so much for your support. So in this episode, we'll be discussing Africa's reaction to the COVID-19 pandemic. And we have just the right person for this conversation. So today we're joined by Dr. Ngozi Erondu, an infectious disease epidemiologist and health systems and global health governance expert. Ngozi's research interests include strengthening disease surveillance and health systems in low and middle income countries. And she has worked with numerous institutions and global health organizations around the world, including the African Centers for Disease Control, the World Health Organization, the Nigerian CDC, the US CDC, and multiple governments around the world in Africa, Middle East, and Southeast Asia. Ngozi is currently a senior scholar at the O'Neill Institute at Georgetown Law and an associate fellow at Chatham House. And, she's also given numerous talks at more than 50 universities around the world on decolonizing global health, which is her other research interest, and we'll get to talk about that. But just to say, Ulrich, I think if we were to read our sister's CV here, it would take the entire episode. But needless to say that she's very accomplished, and she's done quite a lot, had an incredible impact over her career, and we're happy to have you here, Ngozi. Welcome to the show, and thanks for joining us.
Oh, thank you so much, Desmond and Ulrich. It's a pleasure to be here, and I'm really looking forward to this podcast episode. Thank you.
So, Ngozi, perhaps we can start with this. As Ulrich and I were researching this episode, which again focuses on COVID-19 in Africa, our first question that we wanted to discuss was what has happened with COVID-19 in Africa? It seems like, for the most part, most African countries have been spared, right? That is our intuition, that we've been spared. The number of cases have not been as high as in other countries. The mortality seems to be to have been very low, at least what is reported, right? So that's the initial question that we wanted to ask: is why have we been spared? But even before coming to that, do you really think that we have been spared? Right. What does the current data suggest?
Yeah, thank you, Desmond. I think that in your question were several kind of points that I want to expand on. First of all, you said something about, that's what is reported. And so I think one of the big challenges that we have in Africa and countries across Africa is issues with disease surveillance systems. So those are like when you go into the doctor and you say, like, I have malaria, or I have, head pain, or, I feel my heart's been funny. It's the data that gets recorded at that point, right? And that data is what we call surveillance, and it really helps us to stay on top of certain diseases, to understand how many people have that disease, if the disease is increasing or if it's diminishing. And it's really helpful mostly for infectious diseases. So diseases like COVID-19, HIV, malaria, and tuberculosis, and so on and so on. And once we know the scale of a disease or a condition, then we're able to react appropriately. Do we need to bring in vaccines and do, a vaccine campaign? Do we need, drugs to treat it? So because so many, there's several factors going on here. Because so many countries have weak surveillance systems, and because COVID-19 is a novel virus, or the virus is SARS-CoV-2 that actually causes COVID-19, that's new. And also because so many of the symptoms reflect symptoms that you would have if you had malaria, if you would have if you had the flu, and the other many diseases that we fight in Africa. Because of all those things, it's very difficult to really capture the magnitude of COVID-19 on the continent. But what we can say is what you have said about, it seems like in terms of mortality, meaning the people that have died, that we have been spared. Like, even with bad systems, if there are a lot of people that are dying, we would hear about it. And to be fair, we have heard about some waves of deaths in Africa. For example, there were several waves in East and Southern Africa in particular before, during the Delta variant. There were rumors about more imams burying people in Somalia. I even took part of a rumor surveillance project, in the middle of 2020, and this was also, very, very high in Kenya, like people saying that people were dying at home. In South Africa, they had recordings. South Africa obviously has like some of the better systems, and we actually can capture the incidence and prevalence, the amount of people who are dying. So we actually do know that there were certain waves that really affected a lot of people. And even, Desmond, you and I know each other through social media. I remember some of my colleagues in Zimbabwe in January 2021 saying that we're losing our parents, a generation is dying. So we we weren't unscathed, but I would say for multiple reasons. For example, having a young continent, the median age on the continent is 19, whereas the median age in a place like Italy is, between 40 and 60. I don't know the exact age, but we know COVID affected older people more than it did young people. So several things were in place that actually helped to quote unquote protect Africa, but to be honest, we don't actually know the scale of the COVID impact in Africa.
That touches on another question that I have. South Africa is one of the countries that stands out in terms of COVID cases and COVID mortality in Africa, right? It's been significantly higher there than in most other countries, right? Do you think the better surveillance systems and the health system in South Africa accounts for the higher number of cases?
Absolutely. I do believe because they're able to accurately capture cases. A part of this is also disease-seeking behavior, right? So South Africa is one of the most developed countries on the continent. Even though things are not perfect there's a lot of challenges there, just like there are challenges in the West, in different parts of, U.S. and Europe, not. People still have a better disease-seeking behavior than in other countries, meaning that if they get sick, they know if they go to the clinic that there are some things that are going to be covered for them. The clinics are not as far away in South Africa on average as it would be in a place that is more rural or that has less development. And so people go to the clinic, and so it's easier to capture cases of COVID when they actually show up at the clinic, and you can actually test them there. So that's definitely one reason why they appear to have more cases than other people. But also a reason is because a lot of people travel in South Africa, and we know that this was a disease that was imported onto the continent. And so especially at the beginning of the pandemic, the places that were most hit were like, South Africa, Nigeria, Egypt, places that have big airports and a lot of travel. And so especially at the beginning of the pandemic, South Africa did have more cases. And even though mortality was high in South Africa, still compared to Western countries or cities of the same size, or, if you compare Johannesburg, for example, with London or with Rome, it still was much smaller. And I think that's a testament to the South African health system. South Africa has a lot of experience with infectious diseases, including HIV, and they have built out really remarkable systems of testing and treating in the community, very effective communication strategies, and yeah, the country and the communities in the country have a more, I would say, kind of mutual respect with the medical community because of the engagement and because of because of the relationship that was already there. So it's not just about demographics and missing cases. Africa did actually, if you ask me, perform quite well with the resources that they had, and South Africa is a good example of that.
Following up with there's this question about hypothesis of why and if Africa has been spared. The World Health Organization's regional office in Africa quotes that two-thirds of the population have COVID-19 protective antibodies, and we have some of the lowest vaccination rates in the world. So perhaps suggesting that although people have not received the full course of vaccines, there is a higher prevalence of there's a high prevalence of COVID in the population, and that might actually support that we have been spared. Do you have any thoughts on this?
Yes, that I believe that is focusing on a recent study done in Malawi that shows that pretty much Malawians, and that they could have done even a larger kind of seroprevalence study, but it showed that pretty much Malawians had been infected with a variant that was likely Omicron way before the West had figured out that Omicron was spreading. And because Omicron is much more transmissible than earlier variants, a lot of folks had got COVID, had got infected with COVID. And so, yes, of course, being infected with COVID is a natural protector. But I think, we could also say that Omicron is a good variant in some ways, quote unquote, good variant to get infected with, because it is not as severe as especially the first variant of COVID, like the original strain, or Delta. But so we can say that, but also, even the earlier strains of COVID, which people probably got infected with as well, didn't have the same, I would say, destructive impact as it had in the West. And so I think all of this shows that for many factors, Africans were able, again, it's not, we can't say spared as if nothing happened. People died, people got sick. I'm sure there's people on the continent living with long COVID. We're just not seeing the exact same effects. But one, like I said earlier, because we are not able to measure effectively, but two, because of all the other factors that and hypotheses that people have for why Africans or Africa was not as impacted. I mean, one thing that I kind of think about, and I think that is important to think about, is the Spanish flu of 1918 and how there were first, second, third waves, and some of these waves actually did have detrimental effects. Some of these waves still killed a lot of people. I think the third wave was actually a quite virulent strain. And so even though, right now in, March of 2022, we can say, okay, Africa didn't get affected as much as possible. We actually don't want it to get to that point that they would be affected, which is why people are still, talking about vaccine equity or the ability to test and treat Africans and for people on the continent and on low and middle income countries around the world to have access to the effective treatments that do prevent severe COVID or death. So I know we'll probably talk about that later, but just wanted to kind of bring that into context. Is we're not at the end of the pandemic per se, and so it's important to be thankful and grateful that we haven't seen the destruction and the disaster that everybody kind of hypothesized and talked about in the media. But at the same time, the pandemic is definitely not over.
We agree. The pandemic is definitely not over. And from some of your responses, you've already mentioned things like resilience and the importance of components of health system strengthening, and some of the reactions of certain governments like the South African government and researchers down there. So beyond South Africa, how well do you think African governments and public health officials have handled COVID-19?
Yeah, it's a great question, Ulrich. I think as a region, so I think Africa has done one of the best jobs as a region, and I'll tell you why. So we have the Africa Union, which has this agency called the Africa Centers for Disease Control. And within the first 3 months of, China sharing the genotype of COVID or SARS-CoV-2, Africa CDC ensured that all 55 members of the African Union had, I think it's either 54 or 55. I know one of these territories are, contested, but that they had the ability to detect to detect SARS-CoV-2, which is the virus that causes COVID, and that's super impressive. That they had, the ability to send a sample to a laboratory and get a PCR test, and then give someone a result, and that's huge, especially at the beginning of a pandemic where people, where we had the strongest strain of the virus. And they continued after that. Not only did they, strengthen the labs, but they continued doing trainings. They did quite a few missions, so trained field epidemiologists. They sent them from Nigeria to Congo, or Congo to Malawi. You know what I mean? So there was quite a bit of inter-region capacity strengthening and support. And I think that's exceptional. One, because that really helped with the response. I'll also add something else. The government also shut down quite early, when it comes to travel bans and trying to keep this imported virus out of their countries. And I have to say that was a contested decision. The international health regulations really does try to stop travel bans, tries to prevent the disruption of travel and trade. But in this situation where, we didn't even know if you could see symptoms, so many people are asymptomatic and they have COVID. African governments reacted quite quickly. Also, at the beginning of the pandemic, which is the most important part, African governments put several public health restriction measures, and all of the countries did this in order to restrict movement. And some countries really stepped up when in regards to trying to fill that gap, as far as economic disruption as well. So, in Rwanda, in Nigeria, in different places, they looked at the part of the society that was really impoverished, and tried to fill that gap by providing food and meals and things like that. Now, I would say that this is a place that most African governments were weak. I think the North African governments were better with providing support for the households that were most at need, because we know that Africa has a huge informal society, or economy, actually, and so having people stay at home actually can hurt them more than the virus can. You know what I mean? So I would say that I thought that was a weakness, that several countries just told people to stay at home and didn't provide the people who needed the most with the provisions to do so. But overall, I think especially in the early part of the pandemic, there was a lot to laud about African governments.
Ngozi, I couldn't agree more. I think sometimes when we talk about Africa being spared from the COVID-19 pandemic, we fail to acknowledge the efforts of, the governments who and the public health officials in the ministries of health and institutions like the Africa CDC who have had, experience with other outbreaks like Ebola, and were able to get on top of this before it really, went wild. So there's that element of it in saying that we've not only been spared, but there were effective measures that were put in place right at the beginning. And speaking of effective measures, I'm curious to get your opinion, because the African Union, the Africa CDC, aims to vaccinate 70% of the African population by the end of this year, and I know that is a goal that not everybody agrees on. They're saying, let's say, Africa has been somewhat spared. The COVID-19 deaths are not as high, right? Why are we investing significant resources in, COVID-19 vaccinations when, the mortality from other conditions like malaria that have always been there and, other conditions are so high, right? So what's your opinion to this debate about the prioritization of COVID-19 vaccination, even when, mortality from other conditions are much higher?
Oh, Desmond, you're trying to get me in trouble. No, it's an important question. Yeah, so look, I think that there are several things that can be true at the same time. I think that a novel virus that comes into the world that we are not sure how it's going to act after 1 year, after 3 years, after 5 years, I think that we should be as prepared as possible to combat that. And I think that there should be equitable access to vaccines and life-saving drugs to help, like I said about the Spanish flu, for any type of future danger that COVID-19 could pose to Africa. I think vaccines are very important. I've spent most of my career working on vaccine preventable diseases. I've seen diseases that have been really well controlled in the West kill thousands of Africans every year. Specifically, I did my PhD on meningitis serotype A, and we've had a vaccine for that for years in the West. But in Africa, in what they call the meningitis belt from Senegal to Ethiopia, thousands of people were dying yearly. You know what I mean? So now that the world is in my world, it's really interesting to hear people so ardently against vaccines when I know they do save lives. So I'll say that. I think that vaccines are very important. Can we have a better vaccine? Yes, we can have a better vaccine. This vaccine was created quickly, not quickly to the point where it's unsafe, but quickly to the point where it's not as effective as it could be. But that's a whole different argument. I also believe that we shouldn't divert funds from, like you're saying, diseases that always kill our people, right? Malaria is the top killer of children under 5 on the African continent. We still have an HIV epidemic on the continent. Ebola keeps popping up. You know what I mean? So I think that there's a lot of money in this world. I refuse to believe that we have to, take something from one basket and put it in another basket. I think one thing that the global kind of public health structure has quite failed at is, having this innovative financing facilities available for emergency situations like a global pandemic. So I think we need to get better at that. And I think also governments need to get better at that. There needs to be a pot, basically, just like individuals should have some type of like safety pot. Like you should have some type of savings if something happens to you. We have to have the same thing as a government, as governments and as a global society. So I don't think we need to neglect those diseases that still need attention and that we've been fighting for so many years. But that, to me, has nothing to do with getting vaccinated for COVID. I think that the goal that Africa CDC has to vaccinate 70% of the people of Africans before the end of the year is an ambitious but important goal. And I hope that, things like vaccine hesitation, fake news, misinformation doesn't kind of distract from that goal or doesn't make that goal unattainable. I think it's super important.
So Ngozi, you mentioned quite a few times the critical role of the Africa CDC in helping the African continent tackle this challenge that was the COVID pandemic, and sort of a segue into another one of your passions, which is decolonizing global health. We recently followed the confirmation of Dr. John Kangasang, former Africa CDC head, as the head of PEPFAR. So now, I think he will be the first African and non-American to hold that position. So what are your feelings about Dr. John Kangasang's appointment at the head of PEPFAR? And as a segue, we'll be diving into decolonizing global health and vaccine inequity.
So Dr. Kangasang is, I think, one of the most effective public health leaders that I've ever met. I've been very impressed with what he did with Africa CDC. And I think his nomination and I guess his eventual confirmation to lead PEPFAR is going to be transformational. And I say this because, PEPFAR is the U.S.'s contribution to fight HIV. And I think a lot of the money also goes to fight tuberculosis. And like I said, the epidemic of HIV is in Africa. Like it happens in other countries, but not like it happens in Africa. And Dr. Kangasang is a Cameroonian. He's an African. He worked for years at CDC. He helped lead CDC from the ground up. He can offer so much knowledge, so much grounded experience. And I also know him personally. He is someone who believes in Africa-led innovation, Africa-led priorities. He is not a proponent of, what we call like parachute research and white savior syndrome and all that stuff. I've seen him do amazing things by denying like funding from certain countries and organizations that were going to really have uh, fund Africa CDC if they did something X, Y, and Z way instead of the way he wanted to do it. So I think he's a strong leader, and I think that we could see him really redirect. I think PEPFAR overall does much better than some other initiatives or funding. Funding initiatives, I'll say, for diseases, because the HIV community has pushed them so much to do that. The activists and the advocates has done that so much. But I think that he can make them be way more effective and really acknowledge, the population of people who are living with HIV to be able to guide where the money should go as far as services and as far as like policies that need to change to ensure that they are able to access treatment.
So Ngozi, like you said, Dr. Kangasang is a Cameroonian. So obviously Ulrich and I are very biased and very so we very much agree with your point of view, that to have someone of his caliber and his experience and principles running PEPFAR, could have a significant impact. Again, these large institutions are often hard to change, but it's a good thing to have someone with his principles at the helm. The next question, Ngozi, is you've been involved with the Deconizing global health movement for many years now, and you've written numerous papers, academic and non-academic. You've given talks, to multiple universities around the world. How do you think that our assumptions about the way global health is being practiced, or let's just say that the colonial ways in which global health is being practiced, has been revealed or reflected in the COVID-19 pandemic?
All right. So I think that these type of events can be disruptive, but they can bring some good with it. And I think that, I think you guys know what gaslighting is. It's like when you believe something and you think that it's true, but someone is telling you that it's not true, but they're being deceitful. And I feel like a lot of like scholar activists and people who have worked in global health, global public health, especially people, like me from the diaspora, or people actually in the quote unquote global South, in African countries, in Southeast Asian countries, in Latin American countries. Like, we see how global health has been working. We see people coming in, working on projects, taking the data, going and publishing papers, getting a career out of it, becoming full-time professors or tenured professors in really prestigious institutions, while the people who like collected the data, worked on the research, they don't get that recognition. We've seen clinical trials go wrong, or really oppress people or hurt them, and there not being the right protections there. We've seen, how global health has been taught in our universities, where Africans especially always seem like the beneficiaries and not the contributors of public health, and not the innovators of global health. And so I think that we've seen all these things for so long. And then when COVID happened and people weren't able to fly into Africa and save them, when Africans and African institutions rose up and saved themselves, if you want to use that type of wording, we saw that, hey, we weren't making this up. We always had the ability to do so in the first place. We also saw that the folks that were coming to quote unquote save us, that their house wasn't in order. Do you know what I mean? We saw that their health systems were overwhelmed. We saw that their communities didn't believe or trust them. We saw that they didn't have experience fighting infectious diseases like we did on our continent. And instead of like the humility to come and ask us, they were kind of just, actually allowing people to die. And so I think that just the farce that had been global health and the inequities in global health were very evident through COVID. I also think that, this whole thing is we're in it together, solidarity, blah, blah, blah. I think that also came out to be untrue. Like the COVAX facility that was put in place shortly after the pandemic started by WHO and partners was put in place so that, the 40% of people in every country, whether it's, high income or low income, would receive a vaccination once the vaccine, so this was before the vaccines were even developed, once the vaccine was completed. And those were going to be the 40% that were most vulnerable. So the elderly, the people that were immunocompromised and whatnot. And the idea was to, negotiate with pharmaceutical companies to ensure that the vaccine would be accessible and affordable for everybody. And Western countries backed out of their promise to, contribute to COVAX, and they made side negotiations with pharmaceutical companies, making the vaccine completely unaffordable for most low and middle income countries. And then low and middle countries who like Botswana, who decided, okay, well, we need this vaccine, so we're going to negotiate it on our own. They were left to face exorbitant prices from vaccine manufacturers. So really just kind of what was the point of COVAX to begin with? Obviously now things are changing. People are like, I don't know, feeling like they need to contribute. There has been some changes. But like, I think that the pandemic really revealed kind of intention, as well as support and solidarity, and the need for us to have our own capacity and strength and ability to protect ourselves. So I'll stop there. Sorry, that was a long answer.
Preach, sister,
that was...
preach. Preach. Shake tables. I mean, thank you for summarizing it so beautifully. During the pandemic, I was so surprised and not so surprised at the same time when some of the foremost thinkers of how you engage governments in low and middle income countries to make sure that you get your business at the forefront of the agenda were not so inclined or not able to make the same thing happen in their setting. And it was like, oh, okay, where are all those theories that we used to see? Why aren't they in action right now? Thank you so much for making that point. Go ahead, Desmond.
Well, just to add to that, I think, Gozi, you raised a good point, which I would like to follow up on, is we were not surprised. I think most people were not surprised by the reaction from the richer countries to undercut systems like the COVAX, which was meant to ensure equitable distributions and purchase of vaccines globally. Nobody was really surprised. I think we're all watching to see what will happen. And we're like, don't do it, don't do it, don't. And then they did it, and we're like, come on, So, Ngozi, what lessons are there for African governments, African institutions around the next pandemic? Because it's likely that there will be another pandemic. It's likely that there will be something like COVAX that will happen, and possible that the rich countries will do the same thing. So what can be done to prevent it from happening again? Because we saw it coming.
Yeah, excellent question, Desmond. And it's not that it's possible that another pandemic will happen. Another pandemic will happen. On average, we have about 2 to 3 pandemics per century. And it's not possible that the rich countries would do it again. It's definitely going to happen because it happened with HIV. It happened with meningitis. It keeps happening. It will never stop happening. So I think the lesson is, for me, I'm a big proponent of regionalization. I think we should have our own regional pharmaceutical companies. We should have manufacturing of personal protective equipment, so PPE. We should never be in a situation again where our nurses and our doctors don't have gloves and masks and gowns to protect themselves, because that's another big reason that Ebola spread so fast. You know what I mean? It's when you lose your healthcare professionals, you basically lose the war with the pandemic, right? Or with the epidemic or the outbreak or whatever we're going to. So we really need to have that, regional development or manufacturing of all types of equipment. And I hope this is a wake-up call for our governments to invest more into their health systems. I mean, I don't want to really get into why, Africa receives development aid from other countries. But I would just say that my philosophy is that it's not charity, that it is soft power. It is, an exchange for goods. Like, they're not just giving us, money for free. Like, they're taking a lot of stuff too. So on that point, I think our government to take that development aid and invest in a health system, resilient health systems. Like, you can look throughout the world and see, places like Brazil. Brazil is a middle income country. There are a lot of impoverished people in Brazil, but they have universal health coverage. People can go to a public clinic, get treated, get tested, and have some type of follow-up from a healthcare professional. How many African countries can say that besides, South Africa, Botswana, Rwanda? Like, there are not many. And so I hope this is a wake-up call for investments in our health systems and for, accessible and equitable health systems through, universal health coverage, really. So I think, there's a lot of opportunity to strengthen ourselves regionally, as well as nationally. So that's what I would say.
Well, thank you so much, Ngozi. That's a perfect way to end this show. That, there's a wake-up call from this pandemic for Africans, for our governments, for our institutions, to invest in building resilient health surveillance systems and health systems that will, be ready for the next pandemic. Because, like you say, there's another pandemic that is coming, and if we're not ready for it, it's going to be the same situation where, we set up institutions like COVAX and we end up being undercut. And Ulrich and I really appreciate you taking the time to come and join us. Thank you so much for your insights and for the knowledge that you've shared with us and our listeners. Thank you so much, Ngozi.
Yeah, it was my pleasure. Thank you for having me on. And I really hope that, that this was a really helpful episode for your listeners. Thank you very much.
Thank you, Ngozi. Thank you to all our listeners who tuned in. We will share information for how to follow Ngozi on all our social media platforms. She has some very interesting reading and research that she puts out on there. Thank you again for tuning in, and we'll see you next time.